for Dr. Rishi Desai. If you want to know about molecular genetics, he's your guy. He's Chief Medical Officer at Osmosis. Well, you know he's the doctor's doctor. He's the doctor with the mostest. That's the one. That's the line. He has been working at children's hospitals in Boston and LA. He's Dr. Rishi Desai. Come on, take it away. The doctor's doctor.
That's phenomenal. Thank you so much for that. That was really, really good. That's got to be easily the best intro I've ever heard. That was very creative. Thank you for that. So I'm going to give you a clinical scenario. This is hypothetical, but let's say that you have a child in front of you, and this child is coming in because they have a concern for tuberculosis. And in my background, I'm a pediatric infectious disease doctor, so this is something I see quite often. And mom's concerned because they've heard that they have to take isoniazid, a medicine that they may not know a lot about and want to make sure it's not, unsafe for their child to take for a number of months. So this is a very typical clinical visit that I would see. And because I saw it so often, I started thinking to myself, how am I spending my time in these appointments? And is it the best use of time? And so I actually started tracking it. And you can see a little pie chart here, 20 minutes total. A quarter of my time, about 5 minutes, was the history and physical, just gathering up data from mom, asking a little bit about his background, when he started, or if he ever started getting any symptoms. I would then spend about 10 minutes talking about tuberculosis. It's a bacteria. We talk about isoniazid and maybe any side effects that she's heard of or that I can lay out for her. And then at the end of it, the last 5 minutes, usually kind of crunch time because you're kind of watching the clock, making sure you don't get late to your next appointment. I would spend 5 minutes laying out an assessment and a plan. The parent, or in this case, let's say mom, would hear that and then would walk off, and that was the entire appointment. I would kind of do that over and over, that 20-minute loop. And I felt like a tape recorder, thinking, gosh, I'm just saying this canned speech, this 10 minutes over and over and over again. And I would say, why is that? Because if I'm spending so much time trying to make sure that I'm just getting this one canned speech out, wouldn't it make more sense to just be able to send that to a patient ahead of time? And frankly, that's what I started doing. I would send these little emails across to my patients the night before saying, hey, I'm excited to see you tomorrow. Here's a video on tuberculosis and specifically latent TB infection. Go check it out, come in tomorrow, and we can talk about it. And so when parents would receive this from me, it's coming from their doctor, 99% of the time they would make the time in their evening to watch the video so that when they came in, they would be up to speed. And it actually changed the entire flow of the appointment. In fact, what I noticed is that the history and physical 5 minutes was still there, but that assessment and plan, we would just jump right into it and would spend 10 minutes doing that. So spending more time talking about the assessment plan, and then we would have a few minutes, time back. And then if you even captured kind of what that conversation was like, it was different. Parents would say, oh, so I understand that isoniazid is fairly safe. I understand that, the reason you're doing this is not because his lungs are diseased, but you want to prevent that from happening. And I'm basically sitting there nodding away saying, yep, that's exactly right. So they were really leading that conversation, not me. And the other thing that would happen is that we'd spend more time kind of going into it. So they really felt like they had a robust dialogue instead of kind of being this listener for 10 minutes to a lecture that I said, as before, was very canned. So we would walk away from that experience feeling much more fulfilled. I felt like I was actually connecting or bonding with the patient when we did it this way. So I started taking a deep dive into this and thinking about video-based education. The videos that I was showing my patients, by the way, were from Osmosis, the company that I work at. And so I was actually having a heavy hand in creating these videos. And in looking at what's out there, what I realized is that a lot of the education out there, looking at tuberculosis, for instance, it's going to be either a talking head from some authority that we know, in this case, WHO, or it's going to be some sort of PowerPoint, very dense text, lots of bullet points, or some combination of the two, maybe a talking head and a dense PowerPoint with text. There was nothing really that would be interesting or engaging to a patient. So if you're a patient watching this, if you have these 4 thumbnails, the one you're going to most likely click on is the one that's most inviting. It's got a lot of white space. It's got a nice design aesthetic. It's cute. It's friendly. It's approachable. And so that's what we noticed. And we put these videos from Osmosis on YouTube, and the metrics were incredible. Like in total, we have roughly 160 million views. We have 1.9 million subscribers. I'm just through the roof kind of viewage of this content. And it's not, the fact that this isn't out there. There's other content on TV out there. The difference is that we're not competing with the PowerPoints for attention. What we're competing with when you're thinking about patients is this landscape. They could easily be on Reddit or TikTok or Facebook or Snapchat. They're going to these other places, and they're expecting now a certain design aesthetic. They're expecting a certain, thoughtfulness in terms of how content is being displayed, how succinct it is, that frankly, a lot of education is just not delivering. And when you raise expectations from patients and frankly from learners, because learners are really growing up in the same environment, now they're going to come back to their educators and saying, how come you can't deliver information in this succinct way, in this clever or joyful way? So that's really what we're kind of working with now. So I do want to make it clear that, the videos that we make at Osmosis, that I'm in charge of making at Osmosis, it can differ depending on the audience. For a patient, you might focus mostly on the questions that they have around, like I said, isoniazid, or whether it's something around side effects. With, let's say, a learner audience, you might go more into the mechanism of action or the details of pathophysiology. And these whiteboard videos can do all of that and above. So that's why I want to show you these screenshots, just so you get a real visceral sense for the fact that you can show x-rays and pathology and all sorts of things. You're not really limited in any particular way. And that you can really go broad. Our video library is very expansive. We've got videos on all sorts of topics, from epidemiology to physics and pressure volume loops to x-rays. So really any topic that you might need to explain, if it can be done in a didactic way, you can rest assured that it's done on Osmosis, and we've done it in this style. So going to style, one important point is that first impressions matter a lot. And so you'll see with this, thumbnail, for instance, it's very easy to approach. It's full of white space, and it's really inviting. Now, one thing that I always kind of point out is that when you're doing a presentation, the drop off, when people's attention is going to wane, most of that's going to be in the first 20 seconds or so. That's when they're going to say, you know what, this isn't for me. It's too dense. I'm not interested, and walk away. So that first 20 seconds is when you've got your chance to really get in there. And that's why I always start with a hook, something that's going to grab your attention. You notice in this presentation, I started with a hypothetical clinical scenario to really kind of get you in my shoes right away. I didn't start out talking about who I am and my pedigree and all that. Typically, if someone's really interested, they can easily find that out today, just doing a quick search of your name. So they'll know that I'm a pediatric infectious disease physician. They can look up that I work at the CDC or that I work at Osmosis. All that stuff they can look up. What you really want to know is, is this the video for me? And that's why you want to just jump right in there and say that. The length of a video is very important. You don't want to go too long. The sweet spot is around 6 to 9 minutes. And you can see that on this graph where they actually looked at different video lengths to see when the engagement was at its peak. Video format matters, exactly how you say something. So are you going to build up a story, or are you just going to present slide after slide of dense PowerPoint? With text-based especially, it's really hard. So what you want to do instead is, where you can, draw it out, show a figure, show a graph, show, in the case of pathophysiology, show the lungs and the cells that are getting infected in the lungs. Show all that, because that's much more compelling. And finally, the pace at which you speak. So for example, let's say that I start speaking at a very quick pace like this, going, let's say 150 words per minute or even faster. That's going to be much more engaging than if I went to a very slow pace like this, where at this point I may be speaking at 75 words per minute or so. And people find that generally very, very boring and will quickly tune out. Or they might just start to speed it up and go to a 2x or 3x rate and go right back to this, so that you get that experience, even though the initial lecture wasn't able to offer that to you. So you can vary the speed on the learner side just by dialing up and down, but typically a faster pace is much more engaging. And so what I ended up doing as a clinician is I started giving out these clinical prescriptions. I would sometimes do it after a visit or before a visit. And most often nowadays, I do both. To really say, here's what you're going to learn and talk about, have that great discussion. And then as a follow on, have that educational piece as well. A lot of what I do as a pediatrician is education. So this is a big part of that clinical appetite that people have. So what I'd love to do now is transition into a little video montage just to show you the breadth of the types of videos that are out there that we make at Osmosis, so you get a flavor for what's possible.
At Osmosis, we've made over 1,600 videos explaining challenging topics. Let's take a look.
Now, the heart's a three-dimensional organ, right? So V1 through V6 line up in the transverse or horizontal plane of the heart, and each electrode is set up
Today we'll cover how to defibrillate a patient. Normally you do everything on this list, but to keep things concise, we'll focus on the steps in blue. And we'll also
Here's all the equipment you'll need. Neuromuscular blocker medications, personal protective equipment, suction equipment, and a self-inflating bag. When you're ready, take one of those split tape ends and begin sticking it up on the side of the cheek, wrapping the remainder of the tape tightly around the ET tube.
visible in the chest x-ray. In a lobar pneumonia, fluids localized to a single lobe or set of lobes.
Today, we're going to talk about what exactly COVID-19 or novel coronavirus is.
Como el nuevo coronavirus, pueden causar enfermedades más graves.
Amplify your message. Contact us about your next project.
Hey, great, Rishi. Thank you so much for that video. My name is Mark Lee. I'm the chair of the Education Advisory Board, and I have the great pleasure of working with all the divisions of this wonderful foundation of ours. I just want to introduce a panel today that we're going to engage with Rishi, and we have Elizabeth Yu from Spine, Peter Reeve from Hand, Andy Murr from CMF, Lisa Blackrick from Trauma, and Laurent Guillot from Vet. And so we have a wide range of representation for our divisions, but again, it's just a huge opportunity for us, Rishi, to talk to you, and we really appreciate that video because, you know, this is a space that we were pushed into by the pandemic. We're a foundation that has had a long history of pride in face-to-face course offering, and now we've jumped into the online education game. And so for us, what we want to hear from you is a lot about your principles and the, you know, things that sort of guided the development of what you were doing. And, you know, there's going to be lots of questions coming in, but I'm just hoping we can just get some perspectives and you're willing to talk to our group. And I think maybe right out of the box, I just have a question that, you know, I think some of the people may be thinking about while you were showing that is that, you know, those are pretty high production sort of content that you were showing there. And, you know, is there a place anymore for the old school PowerPoint that's sort of been the workhorse of what a lot of us have educated with in the online world?
Yeah, that's a great question. I would say that there are a lot of principles you can look at from other industries. So for example, you can look at movies, for example, documentaries. There's lots of ways of teaching. And how often would one spend time going to a movie theater and watching a PowerPoint? Just think about that. $8 or 12 or 15, depending on where you are in the country. Let's say you wanted to learn a documentary about climate change. That's a topic where there's a lot of dense information. You sit down in your movie theater, you've got your soda, your popcorn, you sit down and you see that it starts playing and it's a PowerPoint. It's a 2-hour PowerPoint on climate change. Just think about that. How quick would you walk out of that movie theater, right? You sat down, you're in a learning mindset, you're a smart guy, you really care about this topic, you took time out of your day to do it. The motivation is there, and the delivery mechanism is PowerPoint. Like you're just tremendously let down. Most people would feel tremendously let down. It would be the unusual person that would sit down and say, like, no, I dedicated this 2-hour window on a Saturday night. I'm going to sit through this, and I'm going to popcorn my way through this. It would be unusual. I think our standards for education changed because it's a frame shift, right? Like when we think of like, oh, I've got to learn about, you know, the spine or the hand, you kind of think, well, how do I normally learn about the spine or the hand? Well, I've come to get used to, I've come to expect or accept PowerPoint. That's kind of my standard. It's a low ceiling. And then when you think about how you learn in other fields, that's not the expectation. That's not what you accept. And so I think what I'm trying to point out is that Learning is not unique. Patients learn, I learn, you learn. We learn about topics every day. And when I learn professionally, more and more, my expectation for learning is going to meet my expectation for learning across the board, which is to say that PowerPoint can play a role. I'm not saying that it can't. It's a powerful tool, but just think about what's most effective. And there is a time and place for that probably, but it shouldn't be the dominant tool that we use. And currently that is the dominant tool simply because we've gotten used to using it. Probably no other reason. It's not the most effective tool. It's not the most efficient tool. It's simply the one that we've gotten used to using. And so that's where we're at. And what I'm suggesting is that there are better tools out there that at the end of the day save much more time and frankly, much more money than using PowerPoint. Because if you think about learning minutes, like the learners, that's an expensive group of folks, paid per hour for their time, and the teachers that are teaching. To be using a pretty ineffective tool is probably not a great use of time.
Great. Hey, maybe I can have Peter unmute, and I'm seeing some questions come in, and Peter had a question about your formatting with that white background. Peter, do you want to ask that question?
Yeah, no, thank you very much. And Rishi, the information is just amazing. It kind of just blew my mind because you're absolutely right that the PowerPoint is not the best way, I think, for us to learn. So my question is, I've seen a lot of different backgrounds, I guess, for the format of these talks. You had mentioned having a lot of white space, but I have heard that, given the audience, maybe even a dark background, that may be good. And then also for the patient, for patient education, the cartoonish illustrations, I think they're really good. But for the medical professional, is that the best route for it, or at least in our areas? We do a lot of surgical videos and anatomy. Is it better just to use video? So a couple of questions mainly on background. What's the best for surgeons as an audience, and also these illustrations if we should just use live video instead of those animations?
Yeah, those are really good questions. So in terms of white versus dark background, there is actually some data to suggest white seems to be a little bit more favorable on the eyes, especially if you are looking for a long period of time. So that's the only point there. Having said that, as you might be familiar, a lot of very common platforms like, let's say, Google Chrome and others allow you to flip out the background for white to dark, or depending on daytime or nighttime viewing. So making those kinds of alterations is now technically not as difficult as it used to be. So you can kind of just invert all the colors depending on user preference. So that's one thing. As far as the cartoonish look, you're totally spot on. Like, I think when you're talking about an audience of patients versus an audience of technical learners, let's call them, I'm just thinking in my head of surgical fellows, that group is going to expect to make sure that the information they get feels like it has authority. And authority gets lost when you have cartoonish characters. So even something simple as like something that looks inaccurate, you can be like, that's not how the lungs look. I can't trust anything then. So the best thing, I think, for that audience, what we found is live video with superimposed illustrations. So for example, or side by side. So for example, you can have a live video showing a surgical procedure. You can animate over it. I mean, the thing most people are familiar with, given that we just had the Super Bowl, I'll use this analogy, but it's like when you watch an analyst look at what happened with the Super Bowl, or like what's happening on the field, they kind of draw on the teleprompter. They say, oh, this player right here, and X's and O's, and they kind of draw out what's happening on the field. Similarly, you can do the same with surgical footage. You take live footage, and then you have an expert go in on top and say, look right here, the angle right here is really off. It shouldn't be 35 degrees. You really are going for 45 degrees right here. And then show the angle and actually draw it in, sketch. That's the best way to learn, because then you have the ability to kind of animate over live footage as well as cross section. So think about this. I can show, let's say, something simple like how to put a PICC line in or how to put a central line in, but you can't really see everything that's going on, especially what's happening below the surface of the skin, right? So then what you do is you take a cross section, you say, okay, this is live footage, keep that in the left half of the field. In the right half of the field, show a cross section and have a medical illustrator come in and accurately show where the bevel of the needle is going in, and how if you go too deep, you're going to puncture the distal wall of that vessel, and you're going to have hemorrhage. So to say, look, you got to make sure you draw back, because that's where you're in the lumen, and then you want to feed the line in, the catheter has to go, and show that kind of in cross section as well as live. So really, for a new learner, they're seeing it from two different angles in real time. They're like, oh, I totally get what you're saying now. versus I've got to imagine what's happening within the part that I cannot see anymore. So that's the sort of advantage you get, but the more accurate, the better for this technical type of learning. And we've done that. And it really works out beautifully because you can do it very efficiently. A surgical procedure that might take, let's say, 6 hours, you can show the critical steps in maybe 23 minutes.
Lisa, you have a comment about that or a question?
I just wanted to elaborate on that. In all of your videos, so I've participated in numerous AO trauma courses, which are geared for the residents. And at this point, every presenter is tasked with making their own presentations. How do you feel about the standardization? Do you feel that having a standardization across the platform for all the content that's being taught or relayed to the learners is important?
It's a good question. And there's a little bit of data I can support with this with. So we asked medical students, we said, hey, med students who are obviously going to be residents in 48 months, depending on where they are in med school. Maybe if they're second years, 36 months away. We said, hey, med students, we have a subset of your content. So most of your content you're getting from, I'll say Stanford Medical School, because I used to work there, is going to be PowerPoint. A subset of it is going to be done in this whiteboard animation style. Would you prefer that all of it be just PowerPoint? That way it's all kind of looks and feels the same. Or would you prefer that a subset, albeit it's not the same, but is done in this let's say, whiteboard animation style? What's better? And by far they said, look, the PowerPoint part stinks. We'll take what we can get with the video approach. And it's a shame that not all of it's done that way. That's terrible, but we'll take what we can get. And so we'll piecemeal it together. That's not a problem for us. We'd rather get some good stuff than just like carte blanche, get none of the good stuff at the cost of, or at the kind of benefit of conformity, or the sense that it's all going to be the same. So in general, what we found, and right now we're in about 20% of med schools. The reason I point that out is that this data is not just Stanford. It's across the board. Most students, and again, these med students are going to be the residents of tomorrow. Very quickly, they're going to be residents. This is what they're saying to us, and they're going to expect something similar in residency if they can get it. So in general, that's the feedback we've gotten.
Great. Hey, thanks. Rishi, another thing, maybe Laurent can comment. We talk a lot about the idea of flipped classroom, and I think Laurent had a question about companion materials. We lost Laurent's video for a second.
Yeah, I'm here. Hey, Richie. Yeah, one of the thing that you covered is that you're going through the basic and the important things that you want to talk about. But unfortunately, it's impossible to cover everything in 9-minute videos. And how do you go about delivering more in-depth content for those that are in demand? Because there's definitely variation in what people want to see and absorb.
Yeah, so a lot of what we do is we will take hour-long lectures. So a standard lecture given by a standard med student faculty member at a standard med school, and we'll take that hour lecture and condense it down into about 10 minutes. So in general, the content density of these videos is pretty high. It's about 6 times what you would get if someone was sort of just chatting or waxing poetic off the top of their heads. So typically these videos are pretty dense. And that's why I wanted that one screenshot of the TV video, because what you see is we talk about Gone complexes, we talk about caseous necrosis, we talk about all the things that one would expect on USMLE step 1 and 2 and 3 in 10 minutes. So it's a pretty dense video. Now, having said that, that's not to say that's everything. So then what we typically do is we'll say, here's a video, do it before you come into class. And when you come in, you can have a case that goes into the application of that video. And the companion materials are going to be typically things like digital notes and questions and things like that. But usually it covers most of it. Now, if it feels like 10 minutes is not enough, great. You can do a second companion piece. And so we've done a couple where it's like 20 minutes of video and two little topics. So we've done a lot of that kind of work with faculty. We've done it at the residency level. We've done it for fellows as well. So these videos, we just did a video on patellofemoral syndrome. Yeah, and it's meant for an audience of surgeons that have been practicing for a while. So these videos can be done on any sort of depth or density of content. The point is that you're typically saving a ratio of like 6 to 1, or let's say 4 to 1 at the very least in terms of time spent.
Great, Rishi. I think Andy has a comment. We have a bunch of questions from the audience I'm going to jump to, but Andy, you have a comment quickly?
Yes, thank you. So Rishi, I really appreciate the efficiency that you're displaying in getting to the meat of information. I do have concerns about the depth of information. You know, we're dealing with sophisticated learners. We're in a surgical field, so there's very little margin for error. I just wonder, you know, learning is not always fun. Sometimes there's hard work behind learning, and you just explain that you sometimes have other assignments with your content. So I find that interesting. But my main question for you is this. In AO, we found that small group learning, case-based learning, actually winds up being extremely important and compelling. Can you explain how you would fold in that type of case-based Socratic style of learning with this baseline information delivery?
Yeah, and a great example for anyone that wants to follow up on how that works really, really well in practice, the Joint Medical Program at Berkeley is a good example of it. So what they'll do is they'll say, hey, we're going to talk about the topic of, and I'm going to stick to the domain I feel most comfortable, which is infectious diseases, but let's try to blend into orthopedics. So let's talk about, like, let's say a rod infection. So if someone's got a rod infection, what would you do? And so we'll talk about that in the sense of, like, what's a biofilm. We'll talk about Staph aureus and coagulative staphylococcus. We'll talk about that in the videos. They come in, and then all they do in class, instead of having a rehash of that, is they'll say, okay, now you've got a 46-year-old man with a rod infection. What are the options? And so then that's where the Socratic method is used by the small group facilitator. And they're essentially just marching through the case. There's no background on coag-negative staph or Staph aureus or how you treat with vancomycin versus linezolid or any of that kind of stuff. That's all in the video. So all that didactic stuff is kind of covered. Now, if they don't know that, great, they can go back and kind of do that on their own time. But in class, that's kind of the expected norm. Now, a lot of students simply don't prepare. We'll say, look, that's great that you assigned that. I don't have time to do that. So then typically what's done in that situation, some med schools do this as well, is they'll, in the first 5 minutes of class, offer a quiz. That first 5 minutes is just spent doing a little quiz. And then the other 55 minutes is spent doing the Socratic method that you're talking about, small group session. That works incredibly effectively. And so if you know in the first 5 minutes you're taking a quiz, people are going to watch the video. If they're going to watch the video knowing they have a quiz on it, they're going to remember that information, really take it to heart. And then they spend 55 minutes really then up to speed applying that content.
Great, Rishi. You know, there's tons of questions coming in as we expected for you. But I think there's a real basic one that I see out there. And it's really that, we're surgeons, vets, we're physicians first and educators second. Is there one piece of advice you think that would really be the most helpful thing, or the thing you see that maybe is sort of deficient when people try to move to the online format?
Yeah, and I'll say I'm a physician first, educator second, in the sense of I get it. That's what I see as well. I have to see patients. I have to do paperwork, et cetera. I believe me, I understand. And so the most important thing that I would say for myself and for all of my peers, if you say, like, what's the most limiting resource you have, it's time. It's not knowledge. It's not anything. It's time. I just don't have enough time. Everyone says the same thing. So if time is your most precious commodity, then let's do something that makes things more efficient and more effective. And so in that sense, any sort of behavior change, learning is a type of behavior. If you want to change how people learn, that behavior change is going to be based on how difficult is it and how motivated am I to do it. Physicians are highly motivated in the sense that they will do whatever it takes to get the best information at the least cost of time. And so that's what people care about. They care about knowing what's accurate, what's up to date, what's the best way to do something, but don't waste my time. And so given all that, why not choose something that is going to be the most efficient thing, which is a short snippet of a video, if it's didactic. Now that's not to say that this one tool is for all purposes. I don't want to advocate for that. But I am saying if it's a didactic sort of thing, whether it's a technical procedure, whether it's how to relay information to someone when their loved one is dead or dying, or whether it's something that's didactic. It could be any one of those types of things. It could be procedural information, didactic information, emotional information, however you want to relay that information or how to express that idea. If you're expressing it and it's a one-way expression, deliver it through a video and then have them practice it in a small group or in a live session. That's the suggestion, and or with simulation. So all those things have a good part of the puzzle, but those are applications. This is the first kind of piece of it.
Hey, great, thanks. I think Elizabeth had a comment that sort of matches a couple of the questions I'm seeing in the chat. And then I think Lisa had felt that way too, is that there seems to be something, we're feeling a loss of the personal interaction or engagement. You want to ask your question, Elizabeth, please?
Sure, thanks. So Rishi, your talk really resonated with me in how I feel like I'm giving the same speech over and over to not only my patients, but also to the residents and fellows and the trainees. So I wanted to get what your thoughts are on how to incorporate the new learner model to trainees, but still maintain that personal interaction with the residents and fellows and medical students with the online lectures.
Yeah, it's a really good question. And it's probably the most important reason that I do this. It's very dehumanizing to have to say the same thing 100 times. You know, any robot or tape player or VHS or DVD or online video, depending on what era you're from, can do that. And so it's really not a great way to go about learning. And it's what drove me crazy. I was thinking, gosh, I just feel like I'm doing the same thing over and over. This is really not fun anymore for me. So I really find that the value for me is in saying, here's a video, I made this video, send me any questions you have ahead of time. Some students will do that. And then when I meet with them in person, we just talk about it. And I say, what was the most confusing part of the video for you? Come in and tell me, I expect an answer there. You know, what was the part that resonated the most? What would you do in the scenario that now you have a 30-year-old that has pre-existing liver disease and is going to be treated for a latent TB infection? What would you do in that scenario? And those are the things that then inspire an interesting conversation. What doesn't is me just giving a canned speech. And so that's the part that is really meaningful to me, and where the in-person or the face-to-face starts coming alive again. It's not face-to-face if it's in name only, you know, in the sense of like, if I'm just giving the same canned speech, but no one's actually giving me any sort of thoughtful feedback, or there's a dialogue missing. So that's one key thing I would say. Another little way that I've started monitoring this is simply, I don't know if you watch Queen's Gambit, the recent movie on chess. You have a clock, and I clock, and then when I'm done with my turn, you clock, and back and forth. Just keep tabs on how much you speak versus how much your students are speaking. In a lecture, it's all on your side. You know, you're spending 10, 20, 30, 40 minutes talking. They're not actually asking many questions, if at all. So when you do it this way, it starts balancing the clock out. All of a sudden, your students are speaking almost half the time that you are.
Hey, great. Hey, Rishi, there's just a super quick question that keeps popping up in the chat is, do you do the illustration yourself, or you hire that out? If somebody wanted to do this, can they just, you know, does this contract work? I mean, it sounds like there was some interest in your style. Just maybe a quick reply to that.
Yeah, sure. So I used to do it all myself. So there was an era where I bought a tablet, cost about $100, and all the equipment cost about $100. The software is free. You could just sit down and do this. Now, if you watch those videos, they look terrible, terrible. I mean, I'm embarrassed that they're out there still. But I made about 300 or 400 of them, and I learned a lot in the process. Now we essentially have changed the model from one person doing everything. I mean, just going back to the movie theater model, have you ever seen a movie where it's all done by one person? No, there's credits, there's an editor, there's a script writer, there's a producer, there's an actor, et cetera. We've done the exact same thing. So we have medical illustrators who are trained in medical illustration school, have a master's degree in that, doing all the illustration, and the anatomy has to be perfect. So you saw the patient education ones. You should see our anatomy videos. They're phenomenal, and they're very accurate down to exactly what should be in what orientation, and they're done beautifully. So they're done by a team, and all that work is kind of chopped out. And so we take in groups like AO or other groups and say, hey, we're happy to do a video for you on this topic or that topic, and that's something that we do professionally now.
Hey, great. Can we take it to a little more philosophical level? One of the things we struggle with is the idea of what should this cost? So should online content be free? I mean, what should be free? What shouldn't be free? How do you think, does it affect the value to the learner, how they look at it? What are your thoughts about that?
So I think every company has to draw their own sort of conclusion on this. I'll just tell you where Osmosis has landed on this. All of our patient education content, which is to say disease content, so diabetes, lupus, et cetera, all that content is freely accessible, and we have no restrictions on that for any kind of learner around the world. So if you're a family member, if your child has a disease, we have a number of rare diseases as well, we have those videos completely for free. So that's where we've landed on it, is patient education is free. For the learner side of it, we charge, and we charge both individuals as well as schools to use our content in their school. And so that's our model for making money. The other place to think about is internationalization. So what you charge in the US may be different than what you charge in Libya or in Syria. So we've partnered with other countries and actually created content and geofenced it to make it completely free of charge in those areas. A small shout out, we did create a whole content for med students and made it free of charge for Syria in a war-torn country where an entire cohort of med students went through on just Osmosis for 1 year for free. And that's awesome. So just knowing that we can do that online is a pretty special thing. And you can increasingly kind of imagine the implications of that in areas that are low resource.
Hey, that's great. But I guess the other, just a perspective, do you think the people that we're trying to reach, the learners, do you think they value things differently if it's free versus paid?
Oh yeah, absolutely. I think that there's no doubt. You know, when someone doesn't have skin in the game, they're much less likely to be motivated to learn. The truth is that with patients, they have skin in the game because they have the disease. So that's why they're motivated to learn about their disease. With learners, typically they do have skin in the game, even if it's not direct. So even if they're not paying Osmosis for the content, they have skin in the game in the sense of time. They're in a program where they have to graduate by a certain time. They need to get a certain grade on a certain exam by a certain time. And so those are motivators. And that's actually probably the most powerful motivation that I see for why those students are coming in to use Osmosis, even when it's free of charge.
Hey, Laurent, you had a question about updating the content?
Yeah, because I mean, I've been at with AO for about 15 years total as a learner first and as a faculty. And then I noticed going year after year that some of the faculty would change their PowerPoint every single time. And some of their faculty, well, they had the same PowerPoint for 15 years. With the video and the implication of involving as many people as you mentioned, it could be challenging to update your materials on time for a given course or event. So how do you go about refreshing content, whether it's because of style or because of new materials are really come to light?
So that's a really good question. We divide all updates into those two categories you just mentioned, so style and content. And the content updates get taken care of first. So a little example, you may recall the hypertension guidelines got updated about a year and a half ago, actually, now with COVID. COVID-19 itself has had updates in terms of the content that we know about COVID-19. Typically for us to update a video, if it's an important update that's content-based, we can update it within about 10 days. So we can take that video, pull it off, so immediately, make the update over 10 days and put it back up and out. So that's something we can do and have done many times, as you imagine. We do rely on subject matter expertise. So we have domain experts that basically police certain domains and say, hey, if there's a major change to lupus guidelines, they let us know, and then we pull that lupus video. Similar for any sort of pathology. So that's typically our approach, but you're exactly right. Most individual professors are having to do all of this themselves. The policing, the updating, that's a lot of work. And so centralizing that work for Osmosis is many orders of magnitude easier than having many professors across the country doing this each themselves.
Hey, great. I think this is a question that came through Andy, but maybe I'll ask it too because it's in the chat and it's really relevant. You know, are you hitting a specific range of learners? Because one of the things that's unique about AO, I think, is that there's a huge range of learners. We're teaching people right out of fellowship to people who have been trained for many years. And we're also teaching a global audience with different educational backgrounds. So is the cartoon really what we saw that looks very cool to us? Does that have broad reach, or how do you think about that?
It's a good question. We actually, so that video that you saw was a patient education video. We have a totally different style guide for what our videos look like for nurses, for example. A lot of those are going to include live footage, like has been mentioned already. The characters are going to be much more lifelike. So even if it is cartoon, it's a very lifelike cartoon, doesn't look silly. And so that's typically what we do. The advantage of using a cartoon, I'll just kind of drop in, is that you can quickly kind of allude to lots of different populations without pointing to one. So I can use a character that could feel relatable for someone in Mexico and could also feel relatable to someone in Canada. And so you don't have to create like just the Mexican version, the American version, the Canadian version, et cetera. So that's one reason why we do that. It's a purposeful choice. But the style differs depending on which category we're going for internationally. And also in terms of the breadth, we have pre-medical students, we have medical students, we have residents, we have fellows, we do CME content. And we also do it across not just, as I said, MDs, but we do DOs, PAs, NPs, RNs, all the way down to we have nursing assistant content. So it's a pretty broad swath of the healthcare force that we're targeting, but only in healthcare.
Great. Hey, Andy, quick follow-up to that.
Yeah. So how do you guard against superficiality? So I'll give you an example. I bought my daughter a used pickup truck. It's got 300,000 miles on it, and the heater core wasn't working. So I didn't want to take it into a shop, and I needed to flush the heater core. So I went onto YouTube. I watched the 10-minute video on how to flush the heater core. I went to the hardware store, bought some tubing, and I flushed out the heater core, and it actually worked. But here's the thing. I'm not a Toyota mechanic, right? But I could flush that heater core. So how do you handle the idea of somebody who gets to the point where they think they know more than they do because they've watched these videos and had education in this manner?
Yeah, and what you pointed out, I mean, this is how people are learning today, Andrew. Like, nobody has time to go take an engineering course or something that you can just do yourself. But the flip side is, like, when do you draw the line? When do you know that you actually do need help? And so there's no way that I could say that every learner out there has drawn the line in the right place or even in the same place. So certainly there are people that are probably going to over-index on confidence when they watch our videos and think, oh, okay, now I don't need to see the doctor. I clearly have X, Y, or Z. I'm good to go. I think the vast majority probably do the opposite. You know, we've had many patients write in and say, look, I saw your video on B12 deficiency. I honestly didn't realize that you didn't need to be anemic to have B12 deficiency. I thought you did. I thought you had to be anemic. And so now I know I have all the other symptoms. I'm going to go to my doctor and say, hey, I'd like to get checked out for this. Now, a lot of doctors on the receiving end will say, well, wait a second, that's not appropriate. We shouldn't be doing that workup. Why are you coming to me? What, you found that on YouTube? So I think that's a discussion that needs to be had and say, like, hey, where did you get that information? Let me tell you why I think you don't have B12. So I think that's a healthy discussion. Having said that, I think that generally speaking, most people that spend the time, 10 minutes, 12 minutes, watching a pretty dense, scientifically based video are going to be folks that are also going to be curious and inquisitive and hopefully humble about the fact that they don't know everything. And so I can't say that we always are striking the right, we're always kind of giving the right information to that person so that they don't kind of over-index on their confidence and don't make kind of poor choices down the road. I certainly hope so. We put disclaimers and things like that on our videos, but that is a consequence and a side effect of putting information out there.
Yeah. Hey, great, Rishi. Hey, we could go for another hour, and it has been such a great opportunity for us to pick your brain on something that we are really trying to explore and understand better. But I'd like to thank the panel, and thanks again, Rishi, for taking the time to be with us.